Did we do all this? I think we stopped at Zika virus, Abi. I think we stopped at Zika. Okay, so let's talk about rabies. So
Yeah.
rabies virus belongs to the family of the Rhabdoviridae. It's the only one in that Rhabdoviridae, and it's a bullet-shaped virus. So it looks like bullet. We can see the image on the slide A. Um, One thing about it is that it causes some cytopathic changes in cells too, leading to formation of some inclusion bodies, which are like aggregate of protein. So the cytoplasmic inclusion that we see in rabies are called Negri bodies. So the Negri bodies are what we are seeing on the screen. That's for slide B. You can see the image B. That's the Negri body. That's what it looks like. So most commonly, they will not show us this image. They will just mention this body. They can mention the Negri body. So Negri bodies, and it's particularly located at the Purkinje cells of the cerebellum and the hippocampus. So the Purkinje cells of the cerebellum and the hippocampal neurons contains the Negri body, which are the inclusions that we see in someone that has rabies. So someone that has rabies, how do they even get the infection? So they typically get rabies from dog bite. So in our own locality here, it's most commonly gotten from dog bite. But in the United States, it's majorly from skunk bite. I think skunk are like um they are like some, is it like rodent now or hyenas? They're actually animals like that. So and it's common in those foreign countries like United States, Canada, and likes. So skunk, raccoon, bat, when they bite somebody, they can inoculate that virus into the blood. And in some cases, you might get the infection through inhalation of aerosol droplets. Um, Particularly, not aerosol droplets from the airway, like inhalation of the um, what's it called, the soil containing the virus. So the virus can exist in caves where bats, lives. So the excreta in that area can contain the virus. So if the person inhale the excreta, the person can get the virus from there. But most commonly, you get the rabies infection from bite from dogs or skunk. So how will the person present? So if the virus comes in through the bite, it enters through the nearby muscle because it typically affects. Do we remember the receptor that rabies use? Anybody?
Nicotine.
Exactly. Nicotine as
Nicotine is
nicotinic acetylcholine receptors,
acetylcholine.
which are located within the skeletal muscle. So once it finds its way into the skeletal muscle, it can move through the neuromuscular junction. And we know that neuromuscular junction is just innervation between the peripheral nerve and the muscle. So from the muscle, it's attached to the muscle through the nicotinic receptor, then find its way to the peripheral nerve. Then for the peripheral nerve, it enters into the spinal cord. Then it can now ascend through the spinal cord to the brain. There, they can cause meningoencephalitis. So, what are the typical presentations that you want to look out for to make diagnosis of rabies? Number one, there's going to be fever. There's going to be normal constitutional symptoms like, you know, nausea, vomiting, malaria, and all those things. But the specific ones include photophobia and hydrophobia. This hydrophobia one is very, very common in people with rabies. It's one of those things that you are going to see in the question that will tilt your mind towards rabies. Once you say hydrophobia, you are thinking of rabies. So they are always very scared of moving close to water. They don't want to take their bait. They don't even want to swallow anything liquid. They are hydrophobic. And of course, they don't want to see light too. They are photophobic. They usually agitate. They are restless. They are agitating. They are confused. They hypersalivate, just like dogs. Just imagine the way dogs, a, a dog that is rabid. The typical presentation of a white dog, they're hypersalivating, they're aggressive, they want to attack, they're agitating, all those things. So, and it's one of those things that you also see in people that have this rabies infection. They are hypersalivating, they have very high fever, they are photophobic, and they are hydrophobic. So, If you are seeing photophobia with hydrophobia, please, this is not bacterial meningitis. This is rabies infection. So agitating, confusion, um, um, photophobia, hydrophobia, hypersalivation. You have problems with the CVS, tachycardia, and all those things. Then everything can culminate into paralysis. So with time, they will get paralytic because that virus can affect the anterior horn cells of the spinal cord, leading to paralysis. Then it can now progress to coma and eventually die. So if somebody um, gets infected with this virus, how does it travel? We've said it that it's attached to the um, what's it called, to the nicotinic receptor in the muscle, then enters to the peripheral nerve, then to the spinal cord. That movement retrogradely to the spinal cord is actually due to utilization of the Dynein motors. That retrograde transport is due to utilization of the Dynein. So we've said this over and over again. There are some particular organisms that use this retrograde transmission. So all these tetanus, these rabies, herpes, you know, those guys that moves retrogradely and hibernate, they use Dynein motor arm to travel retrogradely to the CNS and stay there. So rabies is also one of them. We should take note of that. Yeah. So what do you want to do? If somebody is affected with rabies, what do you want to do? How do you want to respond to that infection? So one thing is just to try and debride that wound. You want to try and clean it. It's just like tetanus. You try and clean the wound. Then you want to give the person post-exposure prophylaxis. You want to immunize the person with acute vaccine so that in case the person gets exposed to that rabies infection the next time, the antibodies are available to easily neutralize those viruses so that they don't even get to enter the CNS and be causing problems. And you also want to, you know, decongest the viral load that is already inoculated. So you want to give the person a passive form of antibody, which is the immunoglobulin. You want to inoculate, you want to give them immunoglobulin to neutralize the virus that is already, in the serum. So that's a form of passive immunity. The vaccine that you are giving is an active immunity because that is going to stimulate the adaptive response so that you can have production of your antibodies and also memory cells that can always respond to the um, virus the next time. This is exactly what you do in someone that has tetanus too. You know, you want to debride, you want to give antibiotics to neutralize, to kill off the organisms. You want to give antisera, you want to give antitoxin. So if you are giving the ATS, the antisera, you are giving immunoglobulin to neutralize the unborn toxin, toxin that have not entered into the CNS, that's still free flowing within the serum. You want to give tetanus serum that contains immunoglobulin that can neutralize them. Then you want to give the person antitoxin, the toxin that's like, sorry, I said antitoxin, toxoid, tetanus toxoid. So your ATS is like your antitoxin. So you want to give them tetanus toxoid in addition to your antitoxin or ATS that can stimulate immune response so that they can be vaccinated against the tetanus. And when the person gets infected with tetanus, the person can neutralize. Exactly what they are doing here by giving the rabies immunoglobulin and giving the kid vaccine. Yeah. So another organism that I also want you guys to watch out for is hepatitis B. I think they give hepatitis B immunoglobulin and they also give the hepatitis B vaccine. So it's another form of infection that you treat, by utilizing the passive active immunity system. Yeah. Okay. So that is that about rabies. What's the shape of the virus? Bullet shape. What's the characteristic cytoplasmic inclusion that we see? The negri body. How is it
Negative
transmitted?
but
Most commonly, dog bite, or in the US, skunk
for
bite,
good.
bat bite, and raccoon bite. In some situations, somebody can inhale the viruses from the soil that contains the excreta of bats. How does it get into the system? So, because of the fact that it's most commonly introduced into the body through the bite will inoculate the virus into the muscle. The virus in the muscle will now attach to the nicotinic acetylcholine receptors in the muscle. From there, they will move across the neuromuscular junction to the peripheral nerve. Because of the fact that peripheral nerves branches from the spinal cord. They travel retrogradely through the dining motor arms to the spinal cord, then they are sent to the brain. When they get to the brain, some of them are going to hibernate within the Purkinje fibers of the cerebellum as well as the hippocampal neurons, and they are going to form the characteristic inclusion body that we call the Negri body. But before they even hibernate, they will have started causing meningoencephalitis, so many disturbances that include fever, malaise. They start having photophobia, they are hydrophobic, they are confused, they are agitating, they become paralytic at the end of the day when they destroy the anterior horns of the spinal cord, and they eventually progress to coma and they die. Very easy. How do you treat? You give, you debride, then you give your passive immunoglobulin to neutralize the viral agents that are in the serum that have not entered the the spinal cord. Then you give vaccine against the next infection. That is all. Okay, so let's go to Ebola. Ebola is a filovirus. So all these viral hemorrhagic fevers, they are just like the same presentation. The incubation period for Ebola is 21 days. 21 days. So after the 21 days, they start having the symptoms. And what do they have? High fever. That's why I remember then in Ebola outbreak, they used to say, once you see someone that has high fever, you want to rule out Ebola. High fever, Lassa fever, Ebola, because very high fever. So most of those viral hemorrhagic guys, even yellow fever, causes high fever. If you guys remember, in addition to the high fever, there is jaundice due to affectation of the liver. There is black vomitus. It can progress to causing encephalopathy to yellow fever. Yellow fever. So the same thing here. They have fever and they have other constitutional symptoms like nausea, diarrhea, vomiting, myalgia, and all those things. But what really defines it as the viral hemorrhagic fever virus is the fact that it can cause coagulopathy, which will lead to disseminated, intravascular coagulation, leading to overconsumption of the platelets, the clotting factors that eventually will lead to bleeding and diffuse hemorrhage. When hemorrhage is very severe, the person is going to go into cardiogenic shock. Abi,
Hypovolemic shock.
hypovolemic shock. Thank you, Dr. Francois. And we have said filovirus is one of those RNA viruses. So the way you can diagnose is by doing reverse transcriptase PCR, so that you can reverse the RNA to DNA. Then you now sequence the DNA with the PCR. That's the way you diagnose Ebola too. So how is it contracted? How do they get it? Bodily fluids. Get contact. Person gets contact with maybe saliva, with with blood, with urine, with anything from the person. They are, all those guys contain very high content of the virus. So formites too, dead bodies, towels, and all those things that it's have been used by someone that was previously infected. The person can get it from them. They can also get it from animals that serve as reservoir for the virus, like bats and primates. So it's one of those nosocomial infection that we get that will spread among health workers, because you know health workers will be the first person that will be in contact with all those people. When they come to the hospital, they don't even know that they have Ebola. They just come with high fever. Then it has not started progressing to the hemorrhage and the shock and the DIC. So they won't know. So they will just handle the person as if they are handling someone that has malaria. And in the process, they get in contact with the bodily fluids and they develop infection after 21 days. So the treatment is basically supportive care. I think we had a patient when I was doing our job that had this Ebola guy, and it was in pediatrics then. The guy was just bleeding from. I never see that kind of bleeding before. If we chook cannula inside, bleed from that side. Put anything anywhere, the guy is bleeding. It's a very terrible situation. So you just want to give supportive care. You want to give the person fluids. You want to give antipyretics for the fever. You want to monitor the vital signs. If the person needs ICU care, you want to take the person to ICU to provide respiratory support and all those things. There's no definitive treatment for Ebola virus. So what you just want to do is just to ensure that it's prevented, and people that you are suspecting that has the infection, you want to isolate them. So vaccinate people. There's a vaccine for Ebola. There's one vaccine, like two forms of vaccine for Ebola. So you vaccinate people against Ebola, especially people that in all those countries that are endemic to Ebola, like Zaire and all those things. To vaccinate people there. Anybody that had contact with someone that is suspected to have Ebola or that even has Ebola, you want to isolate the person for like the 21 days and observe. If the person will eventually develop the condition, and you want to ensure protection of health workers by giving them all those personal protective equipment so that they don't transmit and even infect themselves with the infection by staying in contact with someone that has the infection. So we move to the severe acute respiratory syndrome coronavirus 2, which is a new form of the coronavirus. That's a new form. I think that's many forms. So this is the new form that caused the COVID-19 pandemic. The severe acute respiratory syndrome COVID coronavirus 2. That's what is responsible for COVID-19 pandemic. That terrible pandemic that year. So the clinical cause varies. So, some can be asymptomatic. So people that are very, very immunocompetent, they are very strong immunologically. They can clear off the virus and they don't present anything. But if there's some underlying medical condition, that virus can cause problem, particularly people that are hypertensive. Actually, the most high ranking um, risk factor is actually age. So someone that is advanced in age, you know, it's actually very predisposed to developing symptoms of COVID. So apart from older age, hypertension, diabetics, obesity, COPD, and all those things can predispose to developing the condition. So most infections are mild. That's why you just see many people actually had it then, but because of the fact that the immune status is very good, they just have maybe some little flu and it goes. They don't come down with serious complications. So someone that get infected and the person is developing the symptoms and it's very severe acutely, what do they present with? Typical symptoms like the common fever, they have muscle pain, headache, nausea, uh, nasal congestion, sore throat, GI symptoms, nausea, diarrhea. It's just basically combination of respiratory symptoms and GI symptoms. That's just it. So fever, typically myalgia, malaise, then the respiratory symptoms like cough, like sneezing, nasal congestion, and rhinorrhea. Then GI symptoms, nausea, vomiting, diarrhea. Then what are the specific ones that are actually more specific to the COVID? So they have loss of smell, they have altered taste, so they cannot taste very well. Taste something now, it's tasting different. You know, they cannot perceive smell again. So once it gets to that level, you know that it's becoming very, very serious. Then that should raise our suspicion for COVID, anosmia and dysgeusia. So someone that's having problem with the taste and having problem with smell, please, we should be thinking that's likely to be COVID. COVID. So what's the most serious complication that kill people? Pneumonia. Which other infection did we say pneumonia is the most frequent complication that kills them? Which infection is that?
Measles.
Measles. Measles.
Measles.
Measles. So aside the fact that measles will be causing the subacute sclerosing panencephalitis, aside the fact that it causes encephalitis, aside the fact it causes giant pneumonia, the most common complication that kill them is actually normal pneumonia, either from the measles virus or from superimposed bacterial infection. Same thing applies to COVID. Pneumonia is one of those things that you fear that can kill them because these guys can, readily develop the pneumonia and can progress to acute respiratory distress syndrome fast. From there, it can even develop into sepsis and the person dies. It can trigger hypercoagulability that can cause so many thrombotic events like DVT, pulmonary embolism, and stroke. It can cause hypercoagulability that causes DVT, which can throw an embolus to the lungs and cause pulmonary embolism, and it can go to the brain in some situations, causing stroke. Okay, so if somebody has a DVT and the person is having stroke, what do you guys think is most likely responsible for that? Anybody? Somebody having a DVT and the person is now coming down with stroke. What are you guys thinking?
So the skin. It's an infarct, ischemic stroke.
There's a
Okay, so paradoxical emboli, right?
yeah
Exactly.
PFO
So you
or
are
ASD.
suspecting that that person has a PFO or an ASD. So you want to check out for
Yeah.
that. That's because it's very difficult for the clot to be leaving the pulmonary vessels. Imagine it will now leave those pulmonary vessels and now go back to the pulmonary vein to the left. It will have gotten obstructed at the pulmonary because they are very tiny. So, but if there's a need also for you to bypass that circulation by just moving from the right atrium, to the left atrium, then it can easily cause a stroke. So, so most commonly the stroke from COVID will not be coming from a DVT. It will be coming from hypercoagulability affecting part of the cerebral vessels themselves. Yeah, they can cause myocardial injury, neurological sequel like all this stroke and all these things that we've talked about. It can affect the brain. It can have encephalitis, viral encephalitis, from the ARDS. It can disseminate into septic shock and you can have multi-organ system failure and death eventually. So just picture that it affects almost all the organs. But the major organs that it affects include the brain, the lungs, and the heart. So it affects the brain, the lungs, and the heart. Brain, the lungs, and the heart. So what are the risk factors? We've said it. Advanced age is, one of the most serious and strongest risk factor. Then in addition, obesity and hypertension, COPD, all those things also contribute. You can diagnose it by doing nucleic acid amplification testing, and the specific one is a reverse transcriptase PCR. Sometimes you might want to detect the viral antigen too because it contains this spike protein. Those are the antigens. So you might want to detect that, but that one is not very, very sensitive. You know, it's not very, very sensitive in making a diagnosis of unlike NAAT that is the best. Best thing is just get that genome, sequence that genome and look at it. Don't be looking for antigen. Get the genome and look at it. Yeah. So how does it even get into the body? It spread through respiratory droplets. And of course, we've talked about the attachment of this guy, the angiotensin 2 converting enzyme receptors on the red blood cells. So the major antigenic particle of this COVID are the anti-spike protein. So once it gets into the body is going to undergo seroconversion, producing specific antibodies against those spike protein, producing antibodies against those um, spike protein. Sorry, guys. Sorry. Okay, guys. Yeah. So don't forget that the major antigen, the spike protein, once it once it gets into the body, produce specific antibodies, and the person can be immune toward getting that COVID. Yeah. So that's why if somebody recovers, the chance of the person having it again is kind of reduced because of the fact that the person will have had the antibodies that can protect him. And
Is it a long lasting immunity, something, or it's just
I don't know about the duration. I don't know about duration, but
okay?
at least it will confirm immunity. Yeah, but it's likely to be long lasting because I'm feeling that there's the engagement of the cellular component, you know, because is a protein. So it's stimulating both the mirror and the cellular. So there'll be memory cells. So most likely it will be a long lasting form. But I'm just thinking from what we are. I don't have that specific information with me. So the vaccine comes in different form. You have the series that just give, then the booster, you just want to give that one to just increase the level with time, just like what we do for tetanus and all those things. So all those ones are not very important stuff, but we should just know that there's COVID vaccine, and of course we know that. So someone that is vaccinated, they have reduced risk of contracting the virus again and transmitting it to someone else. Yeah, so what are the treatment options? You can give remdesivir, antiviral agent like remdesivir. Um, remdesivir is like an uh, adenosine triphosphate analog. So what it does is just to inhibit the RNA dependent RNA polymerase of this guy. Now, this guy is a positive sense single-stranded RNA, but it also needs to replicate this single-stranded RNA before they get to protein. Now, guys, we've said that a negative sense RNA virus, we need to convert the negative sense to a positive sense, right? Before it can,
Yeah.
yeah. So if we are saying that, so we should not think that a positive sense RNA virus will not need that. They will need it too, because before they can, produce protein, they need to replicate the RNA. They cannot use one single RNA to be producing all the protein now. So they need to replicate RNA so that they can have multiple copies and convert them to protein differently. So they also use that RNA-dependent RNA polymerase to proliferate their single-stranded RNA. But it's just that this RNA is like equivalent to mRNA, just like we said before, and it will go to protein straight up, straight up. That's very comfortable and convenient for them. So that remdesivir is just like an analog that inhibits that enzyme so that they don't allow it to proliferate. All this nimetervir ritonavir combination and molnupiravir, this nimetervir ritonavir combination, they are like protease inhibitors. So the COVID virus, I think it used some protease enzyme for its replication. So because of that, they were able to develop some protease inhibitor combination to take care of that. So molnupiravir is also an antiviral agent that also inhibits viral replication in someone that has COVID. They will not ask us all these things. They will not ask us. So we don't need to worry ourselves. All these things are even new development. They are new development. They are not even the 2022 version. So I think they just came up with all these things, recently. And we have some monoclonal antibodies that can also work against the COVID. So before we used to talk about DEXA, we used to talk about remdesivir. Those are the only two combinations, and the interleukin 6 pathway inhibitors. Those are the only. So because the interleukin 6 is very important in driving that inflammatory response, so you want to give interleukin 6 inhibitor. Then there's this baricitinib. Sorry, 1 minute, guys. Okay, so and there's this baricitinib. That's one of those JAK start inhibitor. So those Janus kinase replicating pathway. So it just inhibit them and prevent the proliferation of the virus. So it's not very important. If you want to remember them, it's fine. But if I thought you want to remember anything, just remember remdesivir. That one is common. And our protease inhibitors, ritonavir and nematrelvir, then interleukin 6 pathway inhibitors. I think that we are fine. Nobody will really ask us what you use to treat it. So we move to the hepatitis virus. So uh, hepatitis virus, we have about 5 of them. A to E. We are already familiar with some of them. They have some features in common. They can cause jaundice. That's why they are hepatitis virus. They cause inflammation of the liver leading to jaundice, and there's fever. And when there's inflammation of the liver, you have elaboration of your liver enzymes, which includes the ALT and AST. So out of the five, only two share some common similarity, A and E. A and E. So the first and the last one are both naked. They are both naked. So you guys remember when we were talking about those RNA virus and we said the patch are the one that are naked, they are not enveloped. So part of the patch is Picona, and hepatitis A belongs to Picona. And part of the patch E is uh the H rather is the epi. So, you know, no, Yeah, part of the patch. The H is the epi. Now it's confusing me because we use that same patch to code for the non-enveloped. We now use that same patch to now code for the Picona, which is part of the non-envelope. I don't know if you guys get what I'm saying. Hello?
Because one.
Hello?
I think why you looking for
Ah, I can't hear you
hello?
guys though. Please, can you guys hear me? Hello?
Oh, hey, Dr. Baba.
Yeah. Okay. Like I think the network is dragging again. So what I'm just saying is that we use the code patch for the non-envelope. We said once we see non-envelope, we just remove E from the patch and we'll be left with PRCH, right? And our P will be Picona, our C will be Calisi, our R will be the Rio, and our H will be the Epi. Have you now, guys? Is
True.
that not it? Hello?
Yes.
Okay. I think the
Yeah.
network is very bad. Okay. I think I can hear you guys now. So, yeah. So, part of the naked virus, don't let us drag down. The naked virus is hepatitis A and E. They are the naked, they don't have envelope. And they typically thrive in the intestinal tract. So, they are not destroyed within the gut. They are even transmitted fecal orally. That's one thing about them. They are transmitted fecal orally, usually. Although hepatitis A can be gotten when you are having contact with someone that has the infection, but most common route for transmission of hepatitis A is actually fecal oral. Same for hepatitis E. So what are the specific for each of them? So hepatitis B, we said that this guy is a DNA virus, unlike the other ones that are RNA virus. Hepatitis B have a partial double-stranded DNA. It has reverse transcriptase activity. So that means that it can convert RNA to DNA. It can convert RNA to DNA. So, that's that about the hepatitis B. And upon entry into the nucleus, hepatitis B, like we said that day, the partial strand is going to complete into double strand. So once you get to the nucleus of the liver, it gets converted to double strand. Then it can use the synthetic machinery of the liver cells to convert the DNA uh, to RNA, then the RNA to protein. So if it wants to replicate itself, it will now convert the RNA back to DNA so that the protein cannot package around the DNA to form new hepatitis B virus. Yeah, we said that day. I hope you can still remember. Hope I'm not confusing you guys.
Well,
Is it that we don't get? Let me
mm,
say it again. I'm trying to just make the summary because I thought we've already understood that. Oh,
yeah, but can I just say that again? I didn't kind of hear that.
okay. When hepatitis B get into the hepatocyte, it enters into the nucleus of the hepatocyte and the partial double-stranded DNA becomes complete double-stranded DNA.
Mm-hmm.
The liver cells
And
RNA polymerase is going to convert the DNA to RNA. Do you get that?
RNA, yes. Yes.
Now, when it get
And then
converted
the
to
RNA reverse code.
so when it get
Okay.
converted to RNA, the RNA will get converted to protein. They're already synthesizing viral proteins, right?
Okay.
Now, if
Yes.
this hepatitis B wants to replicate, what it will do is that some of those mRNA is going to convert them back to the partial double-stranded DNA through the activity of its own
Using the reverse
reverse
transcriptase.
transcriptase. Now, how does it not form a complete viral? It's now going to take part of the protein that it has synthesized. It will now use that one to package, you know, those partial double-stranded DNA. You know that what makes a complete virion is what? The genome and the what? The capsid protein. You remember?
Yeah. Yeah.
So that is it. So that's how it undergoes replication. You know. So
Mm.
the DNA polymerase reverse transcribes RNA to DNA, which is the genome of the progeny virus. You can see that. One thing about hepatitis C is that hepatitis C lacks the 3' 5' exonuclease activity. What enzyme has this activity? Let me see if you can remember our biochemistry. What enzyme has only predominantly 3' activity? What enzyme is that? Predominantly
Predominantly
3' activity. That's what it have. What enzyme are we talking about? 3'
DNA
X.
polymerase 1, I mean.
No.
no 5' to 3'. That's
The 5?
DNA 1. But
Mm-hmm.
you said predominantly,
3'
so that should be DNA 3.
That's DNA 3. That's the maybe you guys can
That's
Okay,
use
DNA.
maybe you guys can use the starting number. I think that should help you. So 3'5, the one that is starting with 3 is DNA polymerase 3. Do you guys get it? So that is it. Hello?
Yeah.
So the way me I learned it is that if it wants to do the
Yes.
proofreading, normally because of the fact that DNA is being synthesized from 5 to 3, so it has to look back from 3 to 5. It's moving from 5 to 3. You know that if something is going from 3 to 5, that means it's looking back. Do you guys get? So the one that looks back is DNA polymerase 3. But the one that will go to that starting, that one is more superb. It will go back to where you are starting the sentences and start checking it like that. That is DNA polymerase 1. I don't know if what I've said makes sense to you guys. Hello?
For DNA polymerase 1, it cannot print from it.
You cannot what? Hello?
I thought you both from 5 to 3 and 3 to 5.
Yes, it does both. It
That's
does
what
both. It does both,
It
yes.
can.
It does both. That's why I said predominantly only 3 to 5. That's why.
why it is 1. But what was your other one?
No, it's not 1. The one that
Like, you
does
know, the DNA polymerase 1, what it does 5' to 3' proofreading. That's what it does. That's like the DNA 1 this thing. But the one that does 3' to 5' action is the DNA 3.
Yes. DNA polymerase
DNA
1 can also
polymerase
do
3.
3
But
to
DNA
5.
polymerase 1 to do. Yeah.
DNA polymerase 1 can do
Okay.
both. Even that 5 to 3 that is doing is not more of proofreading like that. It's like excision of those um
Sure.
primers. You get so that you can form is excising those RNA primers so that you can lay down Okazaki fragments and join them. That's what it's doing. That's what you mean by the 5 to 3'
That's true.
exonuclease. It's not more of like proofreading. The one that is proofreading is 3 to 5. So
It's 3 to 5, yeah.
you get it now. Do you get it now? All right. So hepatitis C lacks the activity. It doesn't proofread. So that means that
Yes.
its own genome is prone to different errors and mutation. And that means it will be producing different protein at each replication. So that is why hepatitis C naturally has antigenic variation in its envelope protein. Because with time, everything will just keep changing. There's error accumulating. There's nothing to checkmate and correct those errors. So it will be producing different protein at every time. It's just like having antigenic. Which one now? What do we call this one? Is it antigenic shift or antigenic drift? Let me see if you guys can apply that stuff. So what would this one be? Is it antigenic?
Rather drift. It could be
Yeah, you get it. It should be like drift. It should be like drift. So just having different mutation because of the errors, and they are, changing the envelope protein with each replication. So that is why we cannot produce a specific antibody or vaccine against hepatitis C till today. We don't have vaccine against hepatitis C because of that, because we don't even know the specific antigen that represent hepatitis C. There are so many of them. It keeps changing. So if someone gets infected with hepatitis C now, and the first antigen encounter, they produce antibody against it, By the next time, it has changed that surface protein again. Your antibody that you have produced initially will not respond to them, will not work against them. They will change again, and your immune system is always lagging behind. This is just very similar to what we have in which let me see if you guys can remember. Which other condition did we say something similar like this happen? They're always changing their surface antigen. So yeah, the antibody or the immune system is one step behind. Which one is that? Can anybody remember?
H influenza.
H influenza? No. H influenza.
Dengue.
Eh?
Dengue.
No, it's not dengue. It's not dengue. We said it. We said that the fever is recurrent. Because of that, it's recurring. They have recurring fevers. Because of that.
Relapsing. See, I forgot to know.
I want to give you time to remember. That's why I'm
I can remember it, but I cannot pronounce the name.
Oh yeah, tell me what it costs. Tell me what it costs.
Is a zoonotic something. Is it something recurrent to I can't remember. But if I need an option, I'll choose it.
Borrelia recurrentis is correct.
I was going to say Borrelia.
There's another one we talked about. Apart from Borrelia recurrentis. We said it is characterized by recurrent, like relapsing fever that come and they will come again. And sleeping, there's a change in circadian rhythm. We said there's a change in circadian rhythm.
Trypanosoma brucei.
Yeah, Trypanosoma brucei. We mentioned it that day. Trypanosoma brucei.
Let us go right now. Trypanosoma brucei. Change in antigenic relation. Interesting.
Yeah. Have you seen it?
So I'm going back to open it.
Okay. So, that's that. So similar things also happening here with hepatitis C. Changing the antigen, and the strains are changing with time. So what are the family? RNA, Picona, that's hepatitis A, Hepadna, hepatitis B, Flavi, the yellow guys. The code for our Flavi, we said, what's the code again? WYZ HD. WYZ HD. So the H is hepatitis C. Abi, WYZ HD. So the D is the dengue. Abi, then the W is the Western Nile. The Y is yellow fever.
Western Nile, Zika.
Then the Z is Zika.
Yellow fever and then
so we are looking
Zika.
at WYZ in high definition. We are looking at WYZ in high definition. So hepatitis D is the Delta. This one cannot survive without hepatitis B. So basically, they cause the same thing. That's the way to palm hepatitis D. It cannot survive without hepatitis B because of the complementation. They cause the same thing. Hepatitis E is epi. That's one of the
non-envelope.
Epi, yeah, nice one, Dr. Zulia. So don't forget hepatitis A and hepatitis E, both of them fecurally. And hepatitis A is common in travelers. Daycare, they can get it through contact. Shellfish. There's another infection that is transmitted through shellfish. I'm not sure I emphasized it, but there's something.
Vibrio cholerae.
You are Dr. Zulia, you are doing fantastic. Vibrio cholerae, shellfish. That is what you see in the question. I'm telling you guys, it is Vibrio cholerae that you see there. It is shellfish that you see. It is shellfish that they like it. Shellfish, Vibrio cholerae, and you're also paying attention to what's the other Vibrio that causes this wound infection?
Vulnificus.
So
it is something.
Yeah, vulnificus. So hepatitis B, how is it transmitted? Perinatally as well as parentally. So through sexual contact, through blood transfusion, intravenous, and also during delivery. But you guys can see that hepatitis C, they are emphasizing something. They said primarily injection and drug use. I think I've mentioned this before. So this one is not more of sexual contact.
Yeah, injection.
Exactly. So injection, you are not exchanging the fluid through sexual contact.
Sexual contact.
Either you are using drug or post transfusion. Don't forget hepatitis C. Which of the herpes virus can you transmit through post transfusion? Herpes virus. Anybody?
True. What did you call it?
Through transfusion, transfused blood.
Well,
That should
the
be
one is kissing. The two should be.
HBV and HCV now.
Herpes.
No, you're trying to say.
That would be Epstein-Barr. Is that not Epstein-Barr?
Epstein-Barr. Epstein-Barr is kissing
Is
disease.
it Epstein-Barr?
Oh. Epstein-Barr is kissing
CMV is
disease.
CMV is not herpes now. Is CMV herpes?
It is. Oh,
Sorry.
CMV is episode.
I'm sorry. It's
CMV
CMV.
is
Sorry.
type 5. Type 5. We should have pumped this thing spinal level.
Okay.
HHV5, yeah.
HHV5 CMV. Oh. Don't forget to. It is CMV that one is very many. You know, if delivery, that's why it can cause congenital CMV. You know, saliva, blood contact, sex. Just think of anything. Urine, nothing where you know if you transmit CMV is just there. You know, CMV. Which one do you get through sexual contact apart from CMV?
The HSV2.
Yes.
AIDS.
Which one again? Yes, that one is correct. Which one
AIDS.
again?
AIDS.
Kaposi sarcoma. That's it. 8.
The Kaposi. Yeah,
8.
Kaposi.
8. So, B, hepatitis B and D, we said they are the same thing. So, both of them parenterally, sexually, and perinatal. Hepatitis E is fecal. One thing I just want you guys to pay attention to with respect to this hepatitis E is this affectation of expectant people that are pregnant, causing fulminant hepatitis. You know, I've mentioned it before. The reason why I mentioned it then was that so that by the time I'm mentioning it now, it will be as if I'm repeating it.
It's okay.
To stay. That's the reason why I'm saying it then.
E for fulminant hepatitis.
Fulminant. Once that's the only thing that should come to your mind. That's the only relevant thing, because if it affects somebody, it's self-resolving, you know, it will go. It's not a problem, but it is very terrible in people that are pregnant because it's fulminant hepatitis. Now let's go to the incubation period. Everything is short except hepatitis B and C. Those are the chronic guys. Hepatitis B can stay for months to years. Hepatitis C usually years. It's very long. And there's something about hepatitis D. It can infect a liver together with hepatitis B, and we call that co-infection, or it can infect afterwards. After hepatitis B have already settled in, hepatitis D cannot enter. Now, the one that is terrible, that is most feared, is the super infection, because that one can easily progress to chronicity faster than co-infection. Please, we should pay attention to that. Me, I don't understand their coding, short and long. I beg, ignore that. Someone that has super infection, you are having hepatitis D entering a background liver that is already having background HPV infection. It can easily progress to chronicity in about 70 to 80% of the cases. But in co-infection, they are entering together. It will not be chronic. 5% chance of entering chronic. 5% chance. And the most feared complication of these viruses is when you have chronic infection. That is what you don't want. Once chronic infection sets in, person is gone. So, what's the clinical cause? Hepatitis A, very acute, self-limiting. In fact, in children, they don't have anything. In adults, if it happens, some of them can have symptoms. They will have the typical symptom of hepatitis, you know, nausea, vomiting, abdominal pain, jaundice, diarrhea, dark color urine. They will have it like that. You know, they can have it like that. Headache, fever, abdominal pain, jaundice, dark color urine. You know, hepatitis A. But in children, it's asymptomatic. What about hepatitis B? Hepatitis B can also present like, you know, acute infection like what we have said. But if somebody contract hepatitis B as an adult, the person might not really have symptoms, because hepatitis B in adults is usually cleared off within 6 months. You have eradicated it. But in 5% of people, it will stay and it will progress to chronic infection. So if somebody has chronic hepatitis from hepatitis B, then you need to watch out. Because there's high chance of that stuff going to liver cirrhosis. From the chronic hepatitis, it goes to liver cirrhosis, then goes to hepatocellular carcinoma. So Some of them initially they just have something that looks like serum sickness, just have fever, they have arthralgia, they have rash. It's not something that is, it's just like very acute symptom that is not severe. Just have fever,
Mm.
joint pain, and all those things. So within months they will clear it off. They are okay. Okay. The fear is when somebody acquires this hepatitis B in childhood. So if somebody acquires it in childhood, state latent, then adulthood, it progresses to chronicity. That's it. So many people that come down with hepatitis B, chronic hepatitis, at the end of the day, they have had that virus a long time ago in their system. Probably when they were, when they were as a child, they've acquired it. So, that's one thing about hepatitis B. Majority of people that come down with the chronic infection from hepatitis B have had that infection in childhood. So what about hepatitis C? Hepatitis C is the one that has the highest chance of going into chronicity. That one is in fact, the chance is very, very high. When somebody gets infected with hepatitis C, there's a high chance the person is going to develop chronic hepatitis that will go to hepatocellular carcinoma. Very, very high. Even higher than hepatitis B. Yeah.
Mm.
So hepatitis B and hepatitis D are the same thing. They both cause the same thing.
Chronic system.
Yeah, both of them are the same thing because hepatitis D cannot exist without hepatitis B. So if somebody is going to be having hepatitis D at all, hepatitis B will be there because the hepatitis D gets its protein code from the surface antigen of hepatitis B. So what about hepatitis E? It's usually asymptomatic, in normal people, but in people that are pregnant, it can cause fulminant hepatitis. So they will have symptoms of acute liver failure, rapid onset, that will even progress to encephalopathy. They are confused, they are convulsing, go into coma, they can die. They have coagulopathy, symptoms of liver problem. You check the albumin is very low, you check the platelet very low, the clotting factors, everything is low. They are bleeding from anywhere. They're having encephalopathy, they are confused, they are dizzy, all those things. Fulminant hepatitis, and it will rapidly progress to death. That is, so once you see somebody that is pregnant, you are seeing the liver markers that are elevated, you are seeing the synthetic function of the liver being compromised, which is evidenced by the level of the protein, the level of the clotting factors. You are seeing the excretive profile being deranged, elevation of bilirubin. Then you are now seeing CNS problems like confusion, like dizziness, like seizures, like inability to talk and all those things. Now this person has likely developed fulminant hepatitis. Is this person pregnant? So if somebody is pregnant and you are saying that, we should not go and pick hepatitis B or hepatitis C. No, the answer is hepatitis E infection, which is usually gotten fecal orally. So because of the fact that hepatitis A infection is self-limiting, the prognosis is very good. In adults, for hepatitis B, we have said it usually resolves, they clear it off. But in neonate, it's bad because it will stay there and progress to chronicity in adulthood. That is that about neonate. You don't want to, give a neonate hepatitis B infection. Hepatitis C, regardless of age, adult or babies, or high chance of progressing to chronicity. Prognosis for hepatitis D, we have said it. Super infection is worse prognosis because that's the one that will progress to what?
So cirrhosis.
To chronicity. Yes, to cirrhosis.
Super still.
The hepatitis E has worse prognosis in pregnant people because that's causes high mortality in them. So what's the risk for hepatocellular carcinoma? It's only hepatitis B, C, and D that can cause hepatocellular carcinoma. Now, what are the findings? What are the things that we are going to look out for on histology? So for hepatitis A, we are just going to notice that there's going to be swelling of the hepatocytes that are infected by the hepatitis A. They will balloon out. You see cellular ballooning. They are swelling. Then you have monocytic infiltration and Councilman bodies. So these Councilman bodies is also present in an infection. I don't know if you guys can remember. We said it. Councilman bodies. Where?
Calcium, they also see it in this thing now. Is it not measles or something? I mean, calcium bodies. I think
Measles, okay.
that in GIT or in this particular subject that we're talking about in
Yes,
micro.
now, we did it yesterday. Councilman bodies.
Yesterday.
Or day before yesterday, rather. Councilman bodies. I said they are like apoptotic bodies of hepatocytes. They are eosinophilic in appearance. So dead hepatocytes, dead hepatocyte. So we said it though. We said it. Councilman bodies, councilman bodies. Dr. Avisola, you don't remember? Dr. Avisola?
I remember.
Ah, councilman, yellow fever, yellow fever. Don't forget yellow fever. So yellow fever and hepatitis A, they have similarity in terms of these councilman bodies, apoptotic bodies from the dead hepatocytes. So the stain is eosinophilic. We are going to talk about apoptosis today. So we are going to talk about those things. Yeah. So just watch out for the cellular ballooning, the monocytic infiltration, and the bodies, these councilman bodies. What you want to remember for hepatitis B is only ground glass appearance. If they are not saying ground glass appearance in the lungs, they are saying ground glass appearance. In which other condition do we see? In which infection do we see ground glass appearance in the lungs? On radiology, anybody? Ground glass appearance, ground glass.
Is it
Audiology.
acute?
In what?
Ground glass appearance.
Acute. Is it ARDS?
ARDS, is it an infection?
Ah,
That's
ARDS.
reticular.
Ah,
Yeah,
ARDS.
there's
I know what you guys are
reticular.
thinking. You are thinking neonatal form. Okay, in neonatal respiratory distress syndrome, you can see it. Yes.
Yeah, I remember that quite well. Yeah.
Neonatal one, you can see, but there's an infection that we talked about. That's what you see. Ground appearance.
Ground glass.
And in that infection, if you do CT,
Um, is it the
you are going to see nematocysts on CT again. This is
It's PCP, right?
yes. This is PCP. Ground appearance. PCP. Watch out for PCP. What is the color? What is the shape of PCP when you do silver methenamine stain? What is the shape?
Well,
The shape, sickle, I mean,
Well, that is close. We said disc shape. Disc shape.
hmm?
Disc shape yeast. Disc shape yeast. Which one did we say is cigar shape? Cigar.
sporotrix.
Adúpẹ́ o. Adúpẹ́ o. Jésù. Adúpẹ́ o. Sporotrix
It's
skanky.
plenty.
Sporotrix
there are a lot of
skanky.
stuff. It's not as if we are not learning it. We are
I
learning it,
know.
but
I know.
It's plenty.
If you guys ask me to, there will be some words I will have forgotten. Because me, I remember it. It's a lot actually. It's a lot. I know. So don't forget the ground glass appearance is actually due to the accumulation of the surface antigen of hepatitis B within those infected hepatocytes. Don't forget ground glass appearance in the liver, hepatitis B. I've seen a question that these are just what they listed in the option. It's now left for you to now figure out what each of them represent. So ground glass appearance, granular eosinophilic ground glass appearance, accumulation of surface antigen of hepatitis B within the hepatocyte. What's the next one? Hepatitis C. What you are looking for is focal area of macrovesicular steatosis. That is what you are looking for. It causes ballooning of the hepatocyte too. But in this situation, you are going to be seeing something that looks like fat accumulation. So that those fats will be occupying the entire cytoplasm of those cells, and they'll be pushing the nucleus to the periphery. So once you see, I'm sure you guys can recognize fat histology. I think that's the only histology I know in pathology. Fat. That's the only thing I can represent, like I can recognize spinal level. I don't know about you guys. Do you guys know how fat cells look like on histology?
they're white.
Something, all
Like
this,
they're white.
Yeah, you see them white. You see them
With
white.
vacuum or
It's
something
very
like
easy
that.
to
Yeah.
identify. It's very easy to identify. So once you are seeing macrovesicular steatosis, that is hepatitis C. That of hepatitis D is very similar to hepatitis. You can see that they made it easy for us. Everything is similar. D and B, they are the same thing. That of E is just patchy necrosis. So They will hardly ask that one. So we should pay more attention to the A, B, and C. They ask it a lot. So they don't form carriers except the hepatitis B and the C. So hello. So there are no carriers for the hepatitis A and the E. So hepatitis B and C have carrier state, and the carrier state is not very common with hepatitis C. So we've talked about the hepatitis D being the one that is dependent on the hepatitis B before it enters. So if somebody is a carrier of hepatitis D, it means that the person definitely has hepatitis B hanging around. Hello?
Doctor, so that I can get the carrier state, does it mean like chronicity or like what?
Yeah, it just means that the infection is just somewhere in the body. You can say chronicity. It's just somewhere in the body, lurking
Okay.
around, and they can easily shed it. They can release it and, be transmitting it to other people. It's just somewhere in the body, not
Okay.
necessarily in the blood. It's somewhere in the body hanging around, so they can find their way into the blood afterwards. And so most commonly, all these things can actually stay in the liver, and they can get shed into the blood at intermittent period. And when the person gets in contact with the fluid, they can develop the infection. So you get
Okay.
that is it.
Okay.
So, Babawale, the
Yeah,
councilman body, is it for most of them or just for A?
just for no.
Is it only just
It's
for
only
A
for
or
A.
it's
It's
in
only for
others?
A. Then another organism that we said has this councilman body guy is hepatitis yellow fever. Yellow fever. Okay. So what are the extrahepatic manifestations of hepatitis B and C? Yeah. So these ones are IU2. So we have classified them into different types. So for the hematologic, aplastic anemia. So hepatitis B can cause aplastic anemia. And I think part of when we're doing hematology, I think part of the virus that was there includes hepatitis B. I think HIV is also there. I don't know if anybody can confirm. HIV, hepatitis B, they can cause aplastic anemia. Hepatitis C can
Aplastic
cause
anemia, EBV.
EBV. Okay, yeah, EBV is there.
EBV.
EBV is there.
Yeah, EBV is there.
Yeah, I was
HIV.
thinking HIV is there. So if it's not there, then it's fine. Okay.
I don't think so.
Okay, no problem.
CMV, HIV. HIV is there.
Okay.
HBV, EBV, CMV, HIV.
Okay.
So for the other hematologic presentation of hepatitis C, essential mixed cryoglobulinemia. So the way this cryoglobulinemia typically present is they have this purpuric rash. So there's purpura in the skin, there's joint pain, and there's weakness. Once you see that triad, and you are now saying that the person is infected with hepatitis C, my brother, my sister, that is cryoglobulinemia. So if they say it's mixed, that means it's containing both the cold and the warm immunoglobulin. So the cold one is the IgM, the warm is the IgG. So essential mixed cryoglobulinemia. Those guys, those cryoglobulins are just like antibodies that agglutinate or like crystallize, or they form cryoglobulin in response to temperature change. That is it. So it can cause cryoglobulinemia, the purpura, the sorry, there's something I want to say. Yeah, the purpura. And that purpura does not okay, yeah. The purpura, the joint pain, and the weakness, the body weakness. That's the triad. So it can also increase risk of all these B cell non-Hodgkin lymphoma. You guys remember those non-Hodgkin lymphoma now. So it can cause them. It can cause ITP, immune thrombogenic, purpura, thrombocytopenia rather, I said purpura. So there's going to be thrombocytopenia, evidenced by reduced platelets, but increased what? There's reduced platelets, but there's increased megakaryocytes. Because the bone marrow will try to produce more. So you notice that the megakaryocyte is exactly. It's just like, in what condition do you see reticulocytosis?
Okay.
What's the first differential? Reticulocytosis. guys. So if they give us a blood cleaner and they put hemoglobin 4 gram per dl, reticulocyte 10%, we should have differentials like that. The first thing that will come to our mind is hemolytic anemia. When there's hemolysis, the next thing is the bone marrow will try to respond to it and will try to produce more of the red blood cell. So the amount, the precursor red blood cell count is going to be high because they are generating more. That is because just imagine someone has megaloblastic, someone has iron deficiency. Do you think the person will be producing red blood cell like that? I don't know if you guys get what I'm saying. So reticulocyte count will not be very high in all those situations because you're having problem with the nutrients that even need to form the red blood cell. But that of hemolytic anemia is a response to the breakdown. So the red blood cell count will fall, fine, but the reticulocyte count will be high. Reticulocytosis should bring your mind towards hemolytic anemia. And sickle cell anemia is one of them. Thalassemia is another one. Autoimmune hemolytic anemia is a third one. So that is the way to look at it. So the same thing happens here in immune thrombocytopenia. So those guys are having antibodies against the GP11, GP2B and 3A, receptors. That's now making the splenic macrophage come around to chop them off. So in the process, they are taking out the platelets. So because of the fact that it's the splenic macrophage that is chopping them off, the treatment, especially in refractory cases, is splenectomy. You have to remove that spleen if it doesn't respond to anything you are doing. You have given glucocorticoid, you have given rituximab, you have given etropobag, you have given everything. TPO agonist is not working. Remove that spleen. So hepatitis C is also implicated in causing autoimmune hemolytic anemia. So we should remember that. Anemia, hemolytic anemia, thrombocytopenia, cryoglobulinemia, those three things. Cryoglobulinemia, hemolytic anemia, the autoimmune one, and also immune thrombocytopenia with the lymphomas. Hepatitis B is only aplastic anemia. What are the renal manifestations? Hepatitis B has more incidence of causing membranous than membranoproliferative, but hepatitis C is more of membranoproliferative. And I know we know. So you guys just give me one thing that we just use to separate membranous from membranoproliferative. One thing, just one test. What do we see that we say that okay, this is membranoproliferative, this is membranous? Anybody?
I think the spike dome appearance.
Okay.
If I'm not wrong,
membranous will
I
have
was
spike
mixing
dome.
it up.
Okay.
Like for membranous, yes.
So what do you see?
And then the membranoproliferative, that would be like the subendothelial, subepithelial,
no, which one of them?
maybe IG deposit.
Don't bobo us.
So the membranoproliferative. I'm not boboing you now.
Okay,
I know that for the maybe track and tram something for the membranoproliferative. And then the membranous one is the one that has the spike and dome. That's what I think in my head.
Just wanted to
That's
say the deposit.
what I'm trying to remember.
Yeah. Intraglomerular.
Yeah, so the deposit is
for the type 2, intraglomerular.
Yeah, intraglomerular.
For the type 1.
Yeah, it was differentiated.
Subendothelial, yeah. So type 1 is the one that is in keeping with all these lupus nephritis. Here you get. So diffuse proliferative membrane.
Say that again.
You see, the diffuse proliferative and membranous proliferative type 1, they are like the same. So both of them are subendothelial deposit. That is it. So what it's fine that you mentioned all those ones earlier, but just to move quickly, urinalysis. So if you do urinalysis, what will you see in membranous? What will you see in membranoproliferative? Okay.
Because membranoproliferative should be giving us like casts, RBC cast, while the membranous would be like the RBC itself, like that's the nephrotic syndrome. More of nephrotic syndrome, the membranous, while the membranoproliferative is nephritic.
Not proteinuria.
Yeah, Dr. Zulia, you have mentioned proteinuria now. Dr. Zulia.
Okay.
It's even not even the proteinuria gone. It's actually the blood.
It's,
It's blood. But it's just that the card that you are saying, you're just
and
everything is
that's
just
why I
scattered.
said like hematuria. Like I said, gross hematuria for the membranous from the membranous. I said gross hematuria. Why for the membranous proliferative? I said RBC cast. So
Okay.
like
So
differentiates like nephrotic syndrome from the nephritis.
the one that will be easy is that membrane proliferative will give you nephrotic. Bam. Once you see
Okay.
nephritic, you are thinking of two things. Is it SLE? Is it diffuse proliferative? Or is it a membrane proliferative? If it's membranous, you are only going to see nephrotic. That is all. That is all. Oh. That is all.
Okay.
So,
okay.
vascular polyarthritis nodosa. We have already said this. 30% of people with the polyarthritis nodosa will have hepatitis C. Okay. Then leucoclastic vasculitis, which is a vasculitis associated with immune complex deposition within the vessels of the dermis of the skin. So these guys too, we have the rash. So, but the rash of these guys is not blanchable. You can't blanch that rash. So they can also have, arthralgia and other things like that. So, dermatologic sporadic porphyria cutanea tarda. What's the enzyme in porphyria cutanea tarda that is deficient? Anybody?
Urobilinogen carboxylase.
Fantastic, Dr. Decarboxylate, Dr.
I got one question this morning. God, thank you.
Dr. Toby, don't start. I beg. Then Lincoln
Don't mind that, Daddy.
Lincoln
Yeah,
hepatitis C.
we are not moved.
You want to be boboing us there. So you guys
We
should not
are
forget.
not moved at all.
Lincoln planus, porphyria cutanea tarda, hepatitis C. Don't forget. Please don't forget. So if you see someone that has Lincoln planus, you want to rule out hepatitis C in that person. Porphyria cutanea tarda, hepatitis C is one of them. Hepatitis C is there. Exposure to sunlight is another one, and all those things. So the enzyme is what Dr. Adeola mentioned. Hepatitis C also increase the risk of diabetes, mellitus, and autoimmune hypothyroidism. Yeah. So that's the endocrine. DM and autoimmune hypothyroidism.
Sorry, Dr. Gabawale.
Mm-hmm.
You mentioned something about blanching lesions or something. Which one is down?
Non-blanching. Leucoclastic.
Okay.
Abi? Ṣé mo ti gbé fúnra wọn?
Okay.
I've forgotten this one again. That under the skin. What did you say the other day? The
hematopoiesis, the mulberry rash.
Okay, it's mulberry rash.
Yeah.
Which one has mulberry rash?
It's common, but as it.
Hello, what did you guys say?
Then Babale, I'm not saying that. Are we wrong? We said
you said mulberry. Yeah, this where the rash in the touches. Is this network?
Is Dr. Babale's network?
Yeah, I'm here, guy. I'm very here. I'm very much around. I'm very here. So I'm listening.
Are you sure you're very here? Mulberry rash.
Okay.
I said rubella, CMV, toxoplasma.
Exactly.
They have the appearance of that mulberry rash.
Yeah, which is due to what?
I think immune deposits under the skin. I'm not sure. Or bleeding into the skin. I can't remember now.
No,
Sorry.
It's due to dermal hematopoiesis. So there's extra
Okay, extramedullary hematopoiesis. You said it. You actually said it.
Thank you, thank you. That's correct. So let's go back again. And name hematologic problems, hepatitis B, aplastic anemia. For hepatitis C, we are looking at the platelet, we are looking at the red blood cell, and we are looking at the white blood cell. What does it do to the white blood cell? You know, it's not actually the white blood cell now. The antibodies, cryoglobulinemia, the red blood cell, hemolytic anemia, autoimmune hemolytic anemia, the platelet, immune thrombocytopenic, immune thrombocytopenia. Then it can cause the white blood cell problem too, like the B cell, NHL. Okay? Renal, hepatitis
Dr.
B.
Wale,
But
this
it's also called immune
neuroglobulinemia.
thrombocytopenic purpura.
Immune?
Like the Babale, yeah, the ITP is immune thrombocytopenic purpura.
Doctors, yeah.
Yeah.
You know that my brain is very sensitive to information. You now give me I don't want to say you gave me stoof, but don't worry. I won't say.
Yeah, I mean that's why I tried to say it back because I realized that you're not saying the purpura part. That's why I'm like,
You
I
have
hope
given me
I'm not
stoof. So
sorry.
there's a rash. So yeah. So
Dr. Wale, is this cryoglobulinemia that I want to now today ask the question? What should we say?
like three things.
That
The
cold agglutinin.
exactly. If it this one is mixed, so this one is not cold or warm. It's already mixed. It's contain both of them. So what you see is that they will say there's purpura, there's palpable purpura in the body. There is arthralgia, joint pain, and there's weakness. And it will be linked to hepatitis C. They will always mention something, related to hepatitis C in the person. So once you see that, we've seen a question like this before that we have answered. I can't remember who posted the question, Sha, but just watch out for those three things: the purpura, the arthralgia, and the weakness in response to hepatitis C. That's cryoglobulinemia. It's cryoglobulinemia.
Okay.
So renal, we said it, membranous for hepatitis B, membranoproliferative more for hepatitis C. And we said that we are going to identify them on urinalysis. So, vascular polyarthritis nodosa for hepatitis B, leukocytoclastic vasculitis for hepatitis C. Immune complex deposition is what is causing this leukocytoclastic vasculitis. So because of that immune complex deposition, you are going to see fibrinous necrosis of those vessels. We are going to talk about it when we start pathology. So, but I want you guys to have it at the back of your mind now that whenever you see fibrinous necrosis, if you are not ruling out hypertension, you are ruling out immune complex deposition. It means that SLE will cause fibrinous necrosis. Rheumatoid arthritis will cause fibrinous necrosis. Polyarthritis nodosa can even cause fibrinous necrosis. Immune complex deposition things will cause it. Yeah. So dermatologic hepatitis B doesn't have any, but hepatitis C has dermatologic. It can cause the Lenken planus, the porphyria cutanea data, then the endocrine, DM, and hypothyroidism. Okay, they usually has this dermatologic and endocrine, but they like asking the cryoglobulinemia and then maybe the renal. Those are the two that I know that they commonly ask. So let's talk about the serologic markers of hepatitis generally. So hepatitis A has two basic antibodies. So IgM and the IgG. And we've said it. Whenever you see IgM, that means that's an acute infection. Seroconversion, acute seroconversion. So you are producing antibody against the acute infection, like in the acute state. The first antibody that you produce is the IgM. So once you see IgM against a virus, you know that that's likely to be an acute infection. So it's best test to detect acute hepatitis A. That is IgM against the hepatitis A virus. What about the IgG? So that's for prior infection. We will not say chronic infection. If you want to set a question, you say chronic. Some people will pick it and they will bang it because we said it that there's no chronic infection for hepatitis A. Do you guys get it?
Yes.
So if you see IgG against hepatitis A, you not go and pick chronic infection. No. Please, there's no chronic infection for hepatitis A. So it can either mean a previous infection or the person has been vaccinated. That is it. So if there's a prior vaccination against hepatitis A, or there's a previous infection and the person has produced those antibodies against it, it means that the person is already protected. So once the person gets infected, it's not likely that the person will develop the infection because the antibodies are already there. So don't forget, IgG against hepatitis A means vaccination or there's a previous infection that the person has recovered from. That is it. Now let's talk about those components for hepatitis B. So we have the HBsAg, which is the antigen against the surface of hepatitis B. So that one is the one that indicates hepatitis B infection. That is the first antigen that will be introduced into the blood when somebody has hepatitis B infection. HBsAg. You always see it both in acute and chronic. Is there. Acute, chronic, it is there.
Is it also there for vaccine?
No, you not see it in vaccine. You not see it in vaccine. You know, because it's not an active infection. So,
Okay.
in vaccine, the only thing you see is the anti-HBs. That is the only thing. We can check it here. It should be here. So you can see that's the only guy that is there. Anti-HBs vaccine. You move. Once you see somebody that has HBsAg, that person is infected, my brother. Don't even think about it. He's already infected. You just need to decide, is it acute or chronic infection?
Dr. Babali,
Yeah, Dr. Abisola.
can hepatitis A cause fulminant hepatitis?
Omo, I'm not really sure. I'm not really
But
sure.
it's
But
acute,
Question that
Abi.
someone suddenly dies and it can't be hepatitis A, right?
maybe the
So we
person
can.
died from acute infection. The person can also die from acute infection.
That's what I'm saying. It can lead to fulminant. I know B can be fulminant. I know C can be fulminant. But I'm not sure of A.
Well, maybe depending on the immune status of the person, maybe it can be fulminant. I'm not really sure actually too. I'm not sure.
Dr. Babali.
Dr.
No, Toby is saying B and C can be fulminant. Is that? I thought it's only E that we are doing fulminant.
C can be fulminant. I think
Me
B.
too. Yeah, we also talk about
Yes,
it
I'm
because if
sure.
it's going to cause
the thing
hepatocellular
is, what
carcinoma,
I'm saying is, once you see fulminant in pregnant woman, that's what I'm saying.
A.
Shall you
E.
get?
Okay.
You said E now. You said E for fulminant and pregnant. E for
Yes.
egg.
Yes.
I know that one. But regular fulminant hepatitis in a patient
B and C.
from an infectious cause that is not pregnant.
Yes.
I've seen a
Okay.
question like that
B and C.
before. I can't remember.
Yeah, I think.
Exactly.
Yeah, I think I remember something like that. Hepatitis
Yeah.
A can cause fulminant. Yeah, it does.
The person died suddenly from a fulminant hepatitis infection, and I really can't remember. And I know they put eating shellfish, so that ruled out hepatitis A in that question that day. But if I find it, I will.
You know what? Look for that question, Dr. Toby. Please, I'll be very happy if we can see that question. Let us see that question.
I'm not at home currently. I will
Okay.
check and get back to us here.
Okay. No worries.
Dr. Toby, did you say eating shellfish ruled out hepatitis A?
Yes, now.
No, it doesn't rule out.
No.
Shellfish is
I'm
one.
like, why? Should rule it in rather than ruling it out. It's not like oral
Like,
something.
what I mean is that I wasn't thinking of hepatitis A causing that fulminant hepatitis in that. Like, it's really now hepatitis A. How do I put what I'm saying? Like, you can get hepatitis A from shellfish, right? Eating dirty shellfish. So I'm saying that putting if it's in the option, I'm not thinking of A. So I won't pick an answer like that is pointing at A. That's what I'm saying. Do you get? You know
Dr. Babali.
Yes, Dr. Toby, Dr. Odishola.
Can we simply say fulminant is just acute hepatitis?
Yeah, so like acute severe, an infection that is very severe and is
Acute severe.
happening acutely, that is fulminant. So that is it. Acute liver injury, that is fulminant. The person will just be having elevated, bilirubin, coagulopathy, encephalopathy, and all these things suddenly. That is it.
So is C part of it?
They can cause it too. B and C can cause it too. But what is what I just want to bring out is that once you see it in someone that is pregnant, you are likely to think it is hepatitis E. That's just, what I'm just trying to pass across to us. You know what, Dr. Toby? Let us see that question. You will see that it's not something that
I'm
you will not be able to palm.
misinterpreting the
You see,
question.
once you see it, we'll figure it out. Don't worry.
All right,
So,
thanks.
hepatitis B, surface antigen, you said it. Hepatitis antibody against hepatitis B, is not IgM, is not IgG. So we don't characterize that IgG and IgM. It's actually IgG, but we don't say that IgG or IgM because it's only one form. So you can get once you see someone that has the anti-HBs, that person is protected. Either the person has recovered from a previous infection or the person has been immune from vaccination. That's the anti-HBs. So what about the core antigen? The antigen is against the core is present in recent infection too. Someone that has been infected will have antigen against the core part of the hepatitis B. But what is very, very relevant about that one is the anti-HBC, that is the antibody against the core, which is of two types, unlike the HBS. This one is of two types. It has the IgM and the IgG. So someone that has the IgM against the core means the person has an acute infection or a recent infection from hepatitis. It's recent. It has not occurred for more than 6 months. It's a recent infection or is happening acutely at the moment. Antibody against the cause, which is IgM. But if the person has antibody IgG against the core, it means the person has a chronic infection or the person has had a prior exposure. But it's not a marker of the person that is protected. No. It just means there's a chronic exposure or there is previous exposure. So that is it. So look at it. IgM against the core. It can mean two things. Either you are infected currently, acutely, or the person just had that infection within 6 months. It has not gone, even if they are recovered, but it's still within 6 months. The IgM will be there. Once it's beyond 6 months, it means that the person had prior exposure. 6 months later, you'll see your IgG. Or it means that the person has been carrying it for a chronic period, more than 6 months. Or it means that the person has been infected previously. The person has had it previously, but it is not conferring immunity against it. But you have had it before. IgG. Please, I hope I'm not confusing you guys. Let me say it again. If you have the IgM against the core, it means that the person is having it currently at that point, acutely.
And it's within 6 months, have you?
And it's within 6 months.
Oh, it's within 6 months.
That is it. If the person have the IgG, it can mean two things. Is that there's a chronic infection that is more than 6 months, or the person has had a previous exposure to that stuff and it has cleared it. A previous exposure that has been cleared, IgG, but it doesn't confer immunity. The one that confers immunity is when you have the anti-HBs. So the HBE, which
So how do we know
Doctor-
for that IgG?
how do we what?
Doctor,
How do we know which one it is for that IgG after 6 months? If it is prior or chronicity?
No, you can't know. You can't know. You can't know. You now hello? You now continue doing your test. You know that if you want to know that it's prior, the thing is okay. Like what I'm saying is you can't know with this core only. You now need to combine it with HBsAg. So if it's chronic, HBsAg will be positive. If it's prior exposure that has been cleared, HBsAg will be negative. Do you get it now, Dr. Lushara?
What if there is IgG antigen, Tunko?
Eh?
What
Hello?
if there is HBsAg, there is IBS,
Yeah, that's
and
what
there
I'm
is
saying.
IgG?
Look at the question you asked me. You said, I said IgG against the core.
That's a chronic.
IgG against the core is present. It can be two things. Is either the person has had it before and it has cleared, or the person is having a chronic infection. What you can use to separate them is check for HBsAg. If HBsAg is present, that means the person has a chronic infection. If HBsAg is absent, it means it is a previous exposure that's been
Okay.
cleared.
Okay.
That is it. So before we move from this before we move from this antibody against the core, the IgM part is actually very important because it is the one that will tell you if this person is actually in the window period. So window period is a period between when the body is clearing the HBsAg antigen and the person is producing anti-HBs antibody. Please, you guys pay attention to what I said. The window period is the period between when the person, the immune system of the person is clearing the HBs antigen, the antigen against surface antigen, an antibody against the surface antigen is now produced because both of them cannot exist together. One has to leave so that the other one can show. So once they clear the surface antigen, antibody against the surface will now show. So that is it. So the interval between that, for that to happen, is window period. So if you want to know if somebody is actually in the window period, because in the window period, both HBsAg and anti-HBs will be negative. They will not be there. But that person has infection. So what you do is just to check for IgM against HBC. It will be positive. So after the window period, when the person has cleared everything, what do you guys think will show? I'm sorry I'm asking you guys. Let me just see if you guys are actually following. So after the window period, what do you guys, which one do you now, do you guys think will now,
Yes.
No, say it, Dr. Zuliat, I'm with you.
Anti
This
Say it, oh, this is not an exam. Is it my network?
network.
Oh yeah, I'm listening. What did you say?
Network. Network. Is it network?
Okay, I'm listening.
Anti-HBs.
Very correct. That shows you get what I'm saying. The anti-HBs will now show. In that window period, the body is still trying to clear the HBsAg antigen. So it has cleared it to a very low level that you cannot detect it, but it has not gone. But because it has not gone completely, anti-HBs cannot show. So the only thing that you can use to know that that person is infected, but is in the window period, is when you now detect IgM against the core antigen. That is it. The IgM against the core antigen will be positive in the window period. Another thing that will be positive in the window period is also HBe antigen. That one too will be there. Let's see.
But Dr. Wawale,
Sorry,
are you saying that?
Anti-HBe.
Dr. Wawale,
Yeah, I'm listening. I'm listening, Dr. Lushola.
are you saying that when somebody is infected, when someone is infected, first of all, the surface antigen will not show?
No.
Abi,
The surface
that it is only IgM that you can use.
No. The surface antigen is the first antigen that shows. It will be there. You get?
Okay.
It will be there. The next antigen that will follow it is the HBe. If the person is very infective, if the infectivity of that virus is very high, HBe will be formed too in the circulation. You get? Are you following? Hello? Hello? Hello, guys. Are you there? Hello?
We can hear you. Yes, Dr. Wawale.
Yeah, so this is it. If somebody is infected, the first that will come around is the HBs antigen. The next that will show is your core and your HBe. Do we get it? The core and the HBe. Do you understand?
Yeah. Yes.
Now, seroconversion will now start. The person will now be producing IgM against the core. But the body will try to clear, if it's not a chronic infection, if it's an acute infection, the body will try to clear the HBsAg. So the period where it's trying to clear the HBsAg and bringing out anti-HBs is the window period. So in the window period, you cannot detect HBsAg because it has almost cleared it out, and you cannot detect anti-HBs because it has not cleared all the HBsAg, they are still remaining. So you cannot detect both your anti-HBs and HBsAg antigen. The person is in the window period. So what you can use to know that the person is infected is the IgM against the core, because that one will have been formed in an acute infection. Do you get it, Dr. Olushola?
I get it partially.
Wow. Dr. Zuliat, do you understand it?
Yeah, I think I understand it. Quite slow, Darusha, but I think I can.
Can you explain it? Maybe that's where we stop, so that I need to go and rest and prepare for the next class.
Dr. Bawari, let me tell you where my confusion is.
Okay.
It's the fact that I feel you are saying the first thing that show when somebody is infected, you said the surface antigen will show up.
Okay.
Abi,
Mm-hmm.
you now later
Yes.
again come out to say that window period is now when you cannot detect surface antigen because the body is trying to clear the surface antigen with the anti-HBs.
No,
So that's where
you're
my
not clearing
confusion
with
is.
the anti-HBs.
No, the anti-SBS is going
With
to show.
IgM rather, sorry, with IgM.
No,
No,
the
no,
Okay.
body
that's
is
not
trying
what
to
he
remove
said.
it itself. The body is trying to clear it out. It is when the body has cleared it out that they will now produce antibody against it. That's why I'm saying all of
but
them.
how come they will not see the surface antigen during window period when it has already shown first? So that means
Because
there's a
This
it's
is
period
it.
where
it's
surface.
This
trying
is
to
it.
get
Let me
cleared.
tell you something. This is it. There's something we call seroconversion. Seroconversion is not instantaneous. It takes time. That is why adaptive immunity takes time. It's not that when antigen comes in today that you have antibody tomorrow. That is why
Mm-hmm,
sometimes there are some latent period in some tests. The person
mm-hmm,
actually has that infection, but you cannot detect it because seroconversion has not
okay.
happened. Do you get
Mm-hmm.
it? That's the concept of seroconversion. It takes time. So that time before that antibody now shows up is now what we are talking about as the window period.
So window period is when there is no antibody yet. Only, Abi,
Mm-mm.
not about the antigen.
Yeah. So this is it. In the window period, you are clearing the antigen, and the antigen
Mm-hmm.
is at low level. Is at low level. You cannot detect it. Look at, I think this is a chart that can help us. Actually, the chart that is in the previous one is
Even
actually
this chart
important.
itself.
Look,
Okay,
oh yeah,
that means in this window period, there was a time that they could detect the antigen. That's just what I want to know.
no. You cannot detect the antigen in window period. Now look at this chart. Look at this chart. Look at this line. You can see two lines here. Can you see these two
Uh,
lines? Now look at this line 5. Look at the blue curve. What's the blue curve talking about?
I saw that it has
HBsAg.
come down.
You can see that
Yeah,
it
I
has
saw that
come
it
down.
has come down.
Look at the
Well,
upper.
what I'm trying to say is,
No,
was there
look
a
at
time that
wait,
that surface antigen could be seen?
Dr.
Just
Lushola.
not. I'm not talking about window period, though, but before it could be seen, Abi.
It could be seen, but you
Mm-hmm.
don't see it
Yeah.
Okay,
again in the window. That is exactly what we are saying. Look at it.
okay,
Look at the
okay,
window period. You can see that it's come down below the level of detection. You can see.
okay.
Can you guys see that?
Mm-hmm.
Mm-hmm.
And you can see that even anti-HBs is also down below the level of
No,
detection.
it's just about to come up.
What happens
Okay.
after the window period?
The
It
What
says
happens
HBS,
down
after?
surface antigen, Abi.
the anti-HBS is now coming up.
It's not coming
Anti-HBS
up. What happens?
has resurrected.
What happens to HBsAg antigen?
They got buried.
No longer there.
It's got buried. That is it. So the period where you cannot detect both the HBs antigen because you have cleared it to undetected level, even though it's not out yet completely, and the period where you don't have your anti-HBs is just coming is the window period. So the only thing that you can detect in that period is what? Anti-HBc IgM, like you guys can see here. It is the only one that is
Mm-hmm.
overlapping, as well as you know your core antibody, but they don't really emphasize that, but because that's like the total. But the major one is your anti-HBc IgM. That's the one that you usually use to detect your window period. So do you know why the total is elevated too? Because total is talking about both IgM and IgG. Do you guys get that?
Okay,
So
okay.
that one is not relevant. So the specific one that we
So
look out for is the anti-HBC IgM. That's the only one that will be positive in the window.
so
Get.
so let's say in practice now, if you suspect maybe a hepatitis B virus,
Okay.
and then the person is coming to you, you suspect it too. You
Okay.
do the normal surface antigen test.
Okay.
It was negative. You can
Okay.
still suspect that maybe it's in the window period, right?
Okay.
Then
You know
you can
that
now do,
Dr.
you may
Olusola,
do
you know that is a
IgM.
panel. You know that is a panel. You are not doing one.
Okay.
You are not doing one. You do
Yeah, I know,
everything.
I know.
So
I
you
know.
now
I
interpret
like,
it.
okay, you look into, let me say you look into. Hello, Dr. Wale.
I'm listening, oh. I'm listening to you.
So the first one you look into was maybe surface antigen. You saw that it was negative.
Okay.
You now did the panel. You may look into the IgM. It's now positive, right?
Okay.
So that one confirms that there is current infection, but
Yes.
maybe it's in the window period or what?
Yeah, exactly.
Okay.
It's in the window period. So it shows that that person is actually clearing that immunity of that person is actually good. The person is clearing it. That's what it means. So that is that.
This is a really good explanation because the way I used to think about window period. I mean, I know that in the window period of infection, you can't detect antibodies, but I didn't think that prior to the window period, there could be detection of the antibodies. Do you get me?
Okay,
So meaning that in this case, acutely, the antibody can be, does it apply? I don't want to complicate matters, but a simple question, does it apply to HIV?
HIV. That HIV one. Actually, that HIV one, I think it doesn't apply. This one is specific more
Okay,
for hepatitis B. Actually, the window
hepatitis
period for
B.
hepatitis B is actually 2. But I was only emphasizing this one because this is what first aid used.
Okay,
If you read the test, you will see this one and you see the normal one that we all know, that period between infection and when you can detect the antibody.
exactly.
If you I'll make a screenshot now. Maybe wiki or so is on wiki. You see it. The window period for hepatitis B is 2. The period
Okay.
when the person gets the infection and the first time you can detect antibody, that's one window period. The second window period is now this one that we are saying. That when the person is now clearing
Oh,
and the
So that the first is that means the first window period is what we were talking
we
about.
know,
Oh,
yes. I
no,
know.
that's what we know.
That's
And
what
that's
we
what
okay.
know.
applies to HIV too. I think that's what applies to
Exactly.
HIV.
That applies to HIV. Hepatitis B is the only one that its own window period is 2. I don't know this is why they
Right.
ignore the second one. I think they just ignore it because that's the normal thing.
That's the
So
normal one.
that's the normal one. But
That is, you will not yet see the HBsAg in the system.
And we can see from this graph self, they are all not
Right.
starting from 0. See
yes,
the
I'm
graph.
coming. I want to send you the stuff on wiki so that you guys can see it. The window
Sure.
period for hepatitis. I think I saw it somewhere because I was trying to also. Yeah, so 2 periods can be regarded as a window period for hepatitis B. So number 1 and 2. So the period that elapses during HBsAg to HBsAb seroconversion and the period between infection and appearance of HBsAg. So yeah, so I should even say HBsAg, not antibody. So like when the person gets infected and the first time you can now detect, because it is HBsAg that we actually use to detect hepatitis B, right, guys? It's not actually the antibody that you'll be looking first. It is the
Yeah,
HBsAg.
the
Is it there
antigen.
or not?
Yeah.
Exactly. So, and that's the usual one that we know. So the time of
Mm-hmm.
infection and the time that you are able to detect that HBsAg antigen, that's the normal window period everybody knows.
Yeah.
But now, the second one we are talking about is the period that elapses during HBsAg to HBs antibody seroconversion. That is the time between the disappearance of the surface antigen, not even the appearance now, not even the appearance,
The disappearance.
the
Okay.
disappearance
Makes sense.
from the serum and the
When it got
appearance.
buried.
Eh?
I said the time it got buried, the disappearance,
Exactly.
Abi.
Exactly. So, I'm coming. Yeah. So in HIV, the testing for HIV is mostly antibody based. So what you'll be doing for HIV is the period of infection and the period where you can detect the antibody first. That
Okay.
is the window period. Because the test for HIV is antibody based.
It's antibody based. Yeah.
Yes. So that is
Well,
it.
this one is antigen based.
This one is antigen based. So that is it.
Thank you.
So I know that there's no question that they want to bring that we cannot palm. There's no way they will bring it. We'll be able to figure it out. The one thing about this E is just that E is just talking about infectivity. If E is elevated, it means that stuff can be easily transmitted. It is replicating actively and the transmissibility is very high. That's that about HBE. The anti-HBE means that this person has a low transmissibility. That's just it. So let me go and rest, guys, so that I can prepare for this because there are some things I still need to tidy up.
Yes, please. Thank you.
We'll start
Thank
again.
you, Baba.
The next class, we'll start again from that place. We'll revise it again. Then we'll move to HIV and the likes. We are
At
done.
last,
We're actually done with the